I'm going to admit everyone, and then it doesn't look like Mary Catherine's on yet, so I'll wait a couple of minutes maybe to start. Welcome, everyone. We're going to wait a couple more minutes for some of our other guests, and then we will shortly start our program. Thank you.
Hello, Scott.
Sorry, I'm on mute. Good morning.
How you feeling?
I'm doing fine. The eyes are working. That's the good news. I just have to, remind myself to put drops in 4 times a day.
Yeah.
Sorry, I missed the meeting the other day, but I did get the notes.
Oh, good.
Thank you. Sounds like it was very productive.
Yeah, excellent.
Well, once again, welcome everyone and good afternoon. My name is Natalie Ramirez, and I'm a Major Gifts Officer in the Office of Engagement for Catholic Charities. Thank you for joining us today for our Lunch and Learn session on trauma. I would now like to introduce our Executive Director, Bill McCarthy, who will be leading us in prayer.
Thank you, Natalie, and good afternoon, everyone. I'm reading a prayer that was written by our chaplain, Father Ray Chase, and he shared it at an agency-wide meeting on September 8th. Let us pray. God, we call you the Holy One, Hashem, and Allah. All our sacred scriptures tell us repeatedly you are seeking to come into our lives in meaningful and powerful ways. We wish to now welcome you, even as we seek daily to welcome the poor and those in need among us. We are in many ways door people, ever watchful for that next person who comes through the door bearing their need. We know ever so well we will be challenged by that person. We will be challenged to offer ourselves and our services. We will be challenged to find those precious resources that lie nowhere else other than within our own hearts. Respect, compassion, understanding, and a particularly powerful form of love. As we welcome those individuals who come through our doors, we also welcome whatever gifts that person brings and will leave for us. Such gifts are often packaged in what looks like what should be set aside or even thrown away because at first sight, it seems offensive. Yet when we take the risk to look very closely, a skill continually seek to sharpen, we discover some gift of the human spirit that will empower us in our encounter with the next person who comes to our door. So God, Hashem, Allah, bless us Catholic Charities, people of the door. Bless us particularly during this challenging time when fear has caused so much closing of our doors, even closing of minds and hearts. Bless our profound commitment to keep opening doors for those who come to us. For through those doors, blessings beyond measures flow in and out, today, tomorrow, and always. Amen.
Amen. Thank you, Bill, for those inspirational words. Now it is my pleasure to introduce our guest speaker, Dr. Ronald Means. Dr. Ronald Means is a board-certified psychiatrist in the fields of general psychiatry, child and adolescent psychiatry, and forensic psychiatry. He completed his training at the University of Maryland and Johns Hopkins hospitals and holds faculty appointments at both institutions. Dr. Means has been with Catholic Charities for over 12 years. He served as the Assistant Medical Director of Outpatient Services for 5 years until last October when he became the Chief Medical Officer for the agency. In his current role, he is responsible for both treating and monitoring the treatment of children and adults with mental health and substance abuse disorders. He supervises and evaluates the clinical competency of a staff of approximately 20 psychiatrists and nurse practitioners while developing and implementing policies and procedures to ensure effective clinical care. In addition, he maintains a private practice focusing upon forensic psychiatric evaluations of both children and adults. Welcome, Dr. Means.
Thanks, Natalie. So today, the theme of the Lunch and Learn is trauma. There's been a series of talks that have been done on trauma, and this is a continuation of that. The format that I typically use when I'm doing these types of talks is to present the scientific information first, and then usually apply that to case studies that I develop or I can draw from the literature. So that's my standard way of doing these presentations. So forgive me, I'm typically teaching trainees at Johns Hopkins or University of Maryland. I'm applying that same approach here, but I really do want this to be more conversational and more interactive. So there hopefully will be plenty of opportunity for everyone to jump in and ask questions. I know it's somewhat difficult over Zoom, but that is the goal. So before we start the presentation, I wanted to talk about the concept of trauma in general. So I'm going to tell you guys a little secret, okay? You can't let this leak beyond the Zoom presentation, but I actually think that the idea of trauma is being applied too broadly at this point, okay? I know that's a shocker for everyone as a child and adolescent psychiatrist, but I think it's in large part due to a misunderstanding of what trauma means, what the word trauma means. Lately, because of very rightfully so, integrating trauma-informed care into a variety of aspects of our work, whether it be in the educational field or in the mental health field or even in somatic care, trauma-informed approaches and the idea of trauma is being integrated everywhere. And again, I think that overall, that's a really, really, really good thing. My concern is that sometimes the idea of what trauma is being too broadly interpreted, and people are suggesting that or offering that any bad thing or any really bad thing that happens to someone is a trauma or is a traumatic experience. And that's not quite precisely correct. A trauma in itself is an event. It's usually something quite terrible that results in an emotional impact to someone where there's a sense of fear and helplessness and horror, and results in both emotional as well as possibly behavioral expressions of that traumatic event. That's different than just a bad event happening to somebody. So although I am very, very grateful that the idea of trauma-informed care is being so broadly applied, and I do think it's important, I do think there's a little bit of difference in what an actual trauma is. I think that much like myself, much like most, I'm willing to accept this broad approach to trauma-informed care because it does educate people to both be aware of things that are potentially traumatic and just be aware to look for trauma and understand the impacts of those traumas upon us as a society. I think that another reason it's important to understand that not every bad thing is traumatic is that it undervalues or underestimates our sense of resilience. God has built us to be tremendously resilient people. And there's a number of us that go through horrifically bad things. And despite that, we're actually not traumatized by them. That's the majority of us. So I think it's important to understand, and it's hopefully encouraging to us all to understand that we are built to withstand really bad things. And that for the minority, we are traumatized. And when there's a number of these bad things that happen, then we are more likely traumatized. The majority of my work, clinical work at Catholic Charities for the past 12 years has been with the BCARS program, with the crisis program for kids in Baltimore City. And it always astounds me when I see some of the kids that come into the program because people are concerned about the bad things that have happened to them. They're concerned that they're going to be traumatized because they've been through just like horrendous things that I don't even want to begin to mention. And it just really surprises me how often some of those kids come in and despite just being through, atrocious things, they're fine. Like I said, God has really built us to be resilient, especially kids. So I think that's something that we should all keep in mind and again, always impresses me tremendously. All right, so let's get going and start talking about adverse childhood experiences. So similar to, I guess, my lead-in about the definition of trauma, adverse childhood experiences aren't necessarily traumas, okay? They are bad things that happen to kids. Again, kids are not necessarily traumatized by them, but these are the type of things that can lead to trauma. As you will see from this list, there's like many of these things that might have happened to any one of us, right? My parents, divorced, when I was a teen or a preteen. It was a bad thing, right? And it made me sad and it made the family sad, but it wasn't traumatizing, okay? But if you look at these list of things, these are all the things that hopefully we should all know are potential traumatic events for kids, especially. I don't think that this is rocket science. We've known all along that these things, when you have impacts to children by exposing them to abusive situations or violence or substance use, that they're affected by them. And the ACE study that was done in 1995 was a collaboration between the CDC and Kaiser Permanente, essentially went and identified these adverse childhood experiences as things that are potentially impactful to people, things that happen when we're kids that cause potential long-term effects as adults. So when they did this study, they looked at a group of adults who were coming in for regular routine care, and they had them complete surveys. And as part of those surveys, they looked at whether they had any of these things happen when they were children. And then they linked these experiences to the outcomes that people were experiencing now as adults. And they basically found that these adverse childhood experiences result in poor outcomes for people, okay? Potentially because they were traumatized, but in large part just because when you have these types of things happen, they potentially change the trajectory of your development and even change the trajectory of your life, okay? They also found that the more of these you add on, right? So, if you go from 1 to 2 to 3, it's a cumulative effect. So if you have a life, early childhood that's very disrupted, where you have a number of these things, then the prognosis for you worsens. So clearly, being in a home where you're emotionally abused, where you're physically abused, being sexually abused, but also one that we tend to dismiss all too often, coming from a home of domestic violence where you're witnessing violence between parental figures, having a parental figure or a major household member who is actively using drugs or alcohol, having someone who's suffering from severe mental illness in the home, having parental separation or divorce, having an incarcerated household member, being emotionally neglected or physically neglected, are all the ACEs that they identified that potentially lead to poor outcomes for people. Next slide, Dana. So there are also aggravating factors. So these aren't necessarily ACEs, but these are things that make the ACEs even worse for people. So coming from under-resourced, racially segregated neighborhoods, having frequent moves, having food insecurity, being a victim of systemic racism, and having limited educational opportunities all worsen the ACEs. So not only does it make it harder for you to recover from or endure the ACEs, but also makes you more likely to experience them in the first place, right? So, if you are frequently moving or living in an under-resourced neighborhood, you're more likely to have a parent who's going to be incarcerated, or a parent who's using drugs heavily, or a parent who's mentally ill. So these factors, again, worsen the ACEs in not only making you more likely to experience them, but also making it harder for you to rebound from them. For those of you who haven't done so, there's a book called Evicted by Matthew Desmond, and it talks about frequent moves in particular. I think it's something that we fail to understand as a community, and how impactful this is to children in particular, but to families as a whole. It's a really good book that essentially follows people who are suffering from evictions and frequent moves, and it just talks about the impact upon their lives. So if you haven't read it, I would recommend it, and it is very enlightening to talk about the process of eviction, frequent moves, and how it really disrupts the livelihoods of people. All right, next slide, Dana. So this is the way the ACEs work. And this is how they cause impacts upon one's life. So you look at the generational embodiment or historical trauma, that's at the base. These are things like systemic racism, things that are aggravating factors for these ACEs, as well as social conditions, things that we talked about, like coming from under-resourced, poor neighborhoods, having limited educational opportunities. These things set the stage for ACEs to even occur, but also for one to recover from ACEs if they do occur. And then as we move up the pyramid, you see the ACEs themselves, right? Those are the things we talked about: the abuse, the violence exposure, the trauma, the neglect, all of those things that cause an immediate impact on a kid that we know about and we know is linked to poor outcomes. So I think the interesting part is the next step up on the pyramid, where you go to the disrupted neurodevelopment. So this is an interesting thing, and this is really an evolving field in medicine. So what has been shown in the past 5-10 years is that things like post-traumatic stress disorder and traumatic exposures actually disrupt neurodevelopment. So it actually changes the way the brains actually develop, which is incredible to think of, right? We often wonder why people who have had such hardship, we see youth who, grow up in, disrupted homes in Baltimore City, and we wonder why, they might be so volatile or so dysregulated emotionally. And there's actual evidence via PET scans that shows that when you've gone through adverse childhood experiences, it changes the way your brain develops. It makes the parts of your brain that respond to emotion much, much more reactive, okay? It actually decreases the reactivity of the parts of your brain that tell you to stop, right? To maybe ignore those reactions. It actually affects the areas of your brain that impact your memories. So when you put all that together, it's not surprising that people have such tremendous impact from a combination of ACEs when your brain is literally having to change the way it functions because of the environment around you. So as you move up, there is the social, emotional, and cognitive impairment that goes along with ACEs, right? So not only is there disrupted neurodevelopment, but just emotionally, you begin changing the way you behave, and you have to do that. That's the way we're built. We're built to adapt and to protect ourselves when we need to do so. And when you've come from a childhood of constant disruption and exposure to these, ACE after ACE after ACE, then clearly your emotional responses, the way you think, just changes as a adaptive mechanism to dealing with this distress. So as that progresses, you then start developing bad behaviors, problematic behaviors that put you at risk. And as you then adopt more of those behaviors, surprise, surprise, you then have poor outcomes because you expose yourself to disease, to disability, to social problems, because you now have a pattern of behaviors that put you in line to have developed these types of diseases. And then I think the most surprising thing is that this pyramid ends in early death. So it's not just, that people have poor outcomes or live a worse life or don't earn as much money or aren't as educated, but they literally die earlier. because of what happened way down at the bottom of that pyramid, right? In those first 3 steps, they literally die earlier because their life, the trajectory of their life was so problematic and so affected by what happened at the beginning. Next slide, Dana. All right. So thinking about the effects of ACEs. It's part of the ACE study that was done showed the actual impacts of having early ACEs, especially when they start to compound, when you have more and more ACEs added up. And the effects include increased risk of injury, increased risk of sexually transmitted infections. Again, if you're not thinking future oriented, if you're not educated on the impacts to you of potential risky sexual behaviors, if you've been sexually abused and that has decreased some of your boundaries when it comes to your expression of sexuality, when you have little hope for the future and you just don't care, then it's more likely that you're going to engage in risky sexual practices and thereby acquire a STI, a sexually transmitted infection. Not surprisingly, health problems worsen, both physical and emotional health problems. So you're more likely to have chronic illnesses when you grow up, and you're more likely to have a poorer outcome if you acquire those chronic illnesses as well. Again, not surprising, teen pregnancy rates go up if you have higher numbers of ACEs. You're more likely to actually be pulled into sex trafficking. Again, increased chronic diseases, in particular the bad ones like diabetes, congestive heart failure. You're more likely to have those, but also have a worse course of those illnesses. You're more likely to have poorer finances, not surprising again. You're more likely to have an unstable work history. You're more likely to engage in substance use, and you're more likely to be incarcerated. So again, I don't think that when looking at ACEs and looking at the ACE study, again, this isn't rocket science. You're talking about kids who start out already behind, who have a number of significant impacts to them. And as a result of those impacts, they have a poor outcome and a less productive life. I think that the ACE study was instrumental in pointing out specifics, but these general themes should not be surprising. All right, Dana. So I like to do cases. So this is hopefully the more interactive portion of this. I would love for you guys to jump in and say what you think about these cases and point out problems or concerns with them. But whenever I do presentations, I always like to show the scientific information first and then hopefully apply that scientific information to cases. And I'm hoping that these cases are not far removed from anything that we would see in the programs here at Catholic Charities. I can tell you that each of these cases are people that I've seen in some way, shape, or form. Not the exact person, but their general story. All right, so let's talk about little Jimmy, case 1. Little Jimmy is a 7-year-old boy with behavioral problems. I have to minimize my zoom, sorry. Recently, he has been getting in trouble in school and the neighborhood. Little Jimmy is being raised by his grandmother because his mother has problems with addiction and mental illness, and his father is incarcerated. He lived with both parents until he was 4, but there were problems in the home with severe domestic altercations between his parents, as well as drug activity. Little Jimmy frequently witnessed his father attack his mother. Little Jimmy was exposed to intrauterine drugs. In addition, the home in which he was initially raised was in disrepair. He suffered lead poisoning at age 2. Child Protective Services had to place little Jimmy with his grandmother after it was reported that he was being left home alone. Little Jimmy's grandmother is in poor health with chronic medical problems. She struggles to effectively structure or discipline little Jimmy. He struggles academically. It is suspected that he has both learning and attention problems, but neither have been investigated by his school despite his problems. He attends an underperforming South Baltimore public school. All right, let's see how we can do here in terms of having this be more interactive. I would love to hear from anyone to just sort of jump in here and give me your impressions on little Jimmy's case, and talk about what stands out to you as the most problematic aspects of it, thinking of this ACE perspective, these adverse childhood experiences.
Dr. Means, as a father who has an 8-year-old and a 9-year-old boy himself, it's amazing how this doesn't reflect my kid's experience at all. And I think that is, you know, evidence of the gap that a lot of these, that a lot of kids find themselves in. You know, the starting point with which, or the metaphorical starting point at which my kids began life relative to little Jimmy here can't be overstated. So when we talk about outcomes and things like that, it's no wonder that someone like little Jimmy might end up in a far worse place and have far worse outcomes than someone like one of my sons. And that's what stuck out to me the most.
Absolutely. I mean, I think that that's something that I try to get people to appreciate so much. You know, there's so much talk about, you know, folks having an equal life and pulling themselves up by their bootstraps, right? That's the American way. But what I try to express to people is that little Jimmy, you know, much less doesn't have any straps on his boots, but he doesn't have any boots, right? So he's already so many steps behind. But other observations about little Jimmy.
It looks like from reading this, the focus is on placing him, giving him someplace to live versus what he's been through to have to be moved to someplace else to live. So no one's addressing that piece. They think it's just by putting him in another environment, he's okay.
Absolutely. I think that's critical, right? We can't have anything if we don't have security, especially for a kid. You know, we can give them all the therapy and medications and services and so on and so forth. But if he doesn't have a basic sense of security, then all that's in vain. And for little Jimmy, he struggles to have that sense of security because he doesn't have the parental support that he needs in order to develop, you know, appropriately himself.
It seems to me that the learning and attention problems are a result of what he's dealing with. He may not indeed have learning and attention problems. It's more of he's
I think I caught the end of that, but you are right on point. This is, you know,
demonstrating else it's going.
I think that you're bringing up a great point. So these are, again, this is a typical case that I would see in the clinic. This is a typical case that I would see through the crisis program. And it gets so hard to understand sometime, right? Now, Jimmy has many things in his history that make it possible that he does actually have hardwired attention and learning problems, right? He was exposed to lead. He had mom use some drugs while she was pregnant. But you're right, considering the environment in which he's in, considering the lack of support, considering the lack of nurturance, especially from a neurocognitive development standpoint, right? You think about, you know, I think about Pat and what he does with his kids, you know, or as they're, you know, as they're growing and reading their stories with them at nighttime and teaching ABCs and just devoting all those things that we all want to do as parents. Jimmy wasn't getting a lot of that. So it's hard to assess how much of his learning attention problems are due to the lack of the environmental stimuli versus maybe some of these things that really did affect his brain development.
And also being in an underperforming school doesn't help. So there's that second level of, or that layer of attention or watchfulness that other schools may be able to provide. And so he's not getting that support there because they just don't have the resources or perhaps the time to do that.
Absolutely. So that's multifactorial, as we all know as well. You have a school with a number of kids with very high level of needs, potentially with parental figures who are less able, either due to their own limitations or due to their social structure, less able to participate in their child's education and be a support to that school. You have a percentage of kids in that school with a number of problems that the school has to address with their limited funds. And it results in underperforming, to say it nicely, South Baltimore school. All right, Dana, next slide. So here I've identified the ACEs for you, right? So this is a little bit more formalized, where I actually went through and picked out the ACEs here for little Jimmy. So his mother had problems with addiction and mental illness, right? So that's 2 ACEs in one. And his father is incarcerated, so an incarcerated parent. He was a witness to severe domestic altercations. So he again saw mom and dad fighting. This is incredibly common, right, in impoverished, stressed households, that kids are then witness to seeing physical altercations between their parents. We think about the impacts of seeing that type of violence in one's home, where one is supposed to have the ultimate sense of safety, right? It's bad enough that you have to go out into your community and see the violence, but you would hope to be safe when you're in your own home. And you certainly hope to see safety in the interactions between your parents. So Child Protective Services had to place little Jimmy with his grandmother after it was reported he was being left alone in the home. So this is essentially neglect, right? Emotional, physical neglect, because he's being left alone at the age of 7 to tend to himself while, mom and dad are struggling with their own issues. And then, as Aaron noted, he's in an underperforming South Baltimore public school. Not necessarily an ACE in itself, but certainly an aggravating factor for Jimmy. And it makes his recovery from his ACEs much more difficult if he doesn't have an appropriate educational environment to help him overcome the fact that he's already coming in with some deficits. We would assume that Jimmy's in an impoverished neighborhood with limited resources. Assuming that little Jimmy's of a minority population, he's being affected by systemic racism on a daily basis. All those combined to make things difficult for Jimmy. And again, take his boots away that he's supposed to pull himself up by. All right, Dana, next one. So after each case, what I hope to do is show you how we respond, how we here at Catholic Charities respond to these issues as best we can. Very much, when I'm in clinic, I want to change the parents I have in front of me. I want to change the society that the kid or the client that I have in front of me is living in, but I can't do that. So we piece together and we use whatever evidence-based approaches and whatever supports we can put in place in order to help the clients that we have in front of us. And we do this in, I think, a number of really comprehensive, innovative ways. So for little Jimmy, when he walks in the door at the clinic or at the crisis program, or when we see him in one of the schools with which we partner, these are the kind of things that we might do in order to help Jimmy recover from some of those ACEs, in order to help change that trajectory slightly. So we think about school-based therapy, school-based services in general, via our clinic school partnerships. We have embedded in several Baltimore City schools, Baltimore County schools, Anne Arundel County schools, clinicians who provide services to kids right there in the schools. Ideally, we bring the services to them in order to make it more accessible. We not only provide a service for those kids, but also provide a service for those schools who struggle to get kids the right resources. And hopefully make it a little bit more easy for families to access the resources too, as we hope that they would be able to come to the schools maybe a little bit more easily than they might be able to come to clinics. As part of whatever services we do, whether it be school-based services or in the clinic services, we provide psychiatric evaluation and treatment. Okay. For Jimmy, things that we might want to start thinking about, considering he's at risk for things like ADHD, attention deficit hyperactivity disorder, right? He was exposed to lead, exposed to drugs while in utero. Those things might have caused some hardwired changes in his brain that might necessitate medications. We also do things like provide adjunctive or supportive services, things like psychiatric rehabilitation programming, which in large part for the smaller children, the goal is to help in behavioral management training for parents, but also to help with social skills training for the kids, teach them things like how to get along with other kids appropriately, anger management, organizational skills, right? We want to think about kids as comprehensively as possible, and it's not just about the medications, it's not just about working on the emotional trauma via therapy, it's also about giving them very practical skills and programming like psychiatric rehabilitation programming can aid in that. We also offer family support. It's critical, right? If we don't do something to help get this family the support it needs, and we can't do that just through family therapy or through behavioral management training, we also just want to give support. And that might be via support groups, okay? And where we bring the families into the clinics. Right now, we do it via Zoom, but have them meet other families so that they can get tips from other family members, or hear about other ways that we support family members, or just us being aware that we don't have all the answers sometimes, and that sometimes it's useful to have other family members have family members talk to each other, and sometimes offer some supports or resources that way. Or we might offer respite services. We might know that little Jimmy's grandmother is overwhelmed and she can't manage little Jimmy all the time because she has to get to appointments or she's just tired. So we might offer respite services and have Jimmy be gone for the day with one of our respite providers, just to aid in getting some relief for little Jimmy, or little Jimmy's grandmother in this case. And then if little Jimmy's problems escalate, we might think of things that we also offer, like offering crisis intervention services, a more amplified, intensified level of service if things are really getting out of control for Jimmy. We might think that Jimmy does have significant learning problems and is failing in his school. So we then might refer him to our own Villa Maria school in order to get specialized education. Or if it really seems that Jimmy's struggling in the community and we can't manage him in the home with his grandmother and all of our outpatient services are failing, then we might even refer little Jimmy to St. Vincent's Villa and have him get residential care for some time in order to help him become whole again and then be able to transition successfully back into the community. So these are some ways that we might respond, services that we offer through Catholic Charities to help little Jimmy despite the number of problems that he came to us with. All right, Dana, next case. All right, so here's case 2. This is JJ. All right, so JJ is a 17-year-old teenager. He has recently quit school after years of failure and truancy. He has been arrested twice for assault and robbery. The second time, he was placed on probation with mandated services, including GED programming. JJ is an angry teenager. Aggression is JJ's only expression of emotion, but it is suspected that there is much pain behind the anger. He also smokes marijuana daily and has misused some prescription opiate medications intermittently. He is reckless with his sexual practices. JJ's mother, with whom he lives, is tired of his misbehavior and disrespect. She is no longer making an effort to supervise or discipline him because he does not listen to her. His severe behavioral problems are so upsetting to her that she worries about compromising her 2-year history of abstinence from heroin due to the stress. All right, tell me your thoughts about JJ, everyone. What do we think?
I think you have to try to figure out, what's behind all the anger. You have to, it's like a cold, your nose is running. That's not the issue. It's you got a cold.
I agree. I think that this is a common presentation for a teenager that we would see, who's just, forgive my language, pissed, right? They're mad. They're mad at the world. And teenagers, this is how they express that, especially the teenage boys. And getting at what's driving that anger, driving that aggression, driving that frustration is the hardest part of all of it, while trying to keep them engaged in believing that we can do something to help. Any other thoughts about JJ?
Dr. Means, I was thinking of JJ's journey. You're picking it up here at age 17. JJ could have had similar experiences that little Jimmy had in your previous case before. And so it's kind of seeing the whole journey and how do you address, and work with JJ at this point.
I absolutely agree.
Dr. Means, one other thing that I noticed, and this is maybe something you can speak to a little bit. The intervention, I've heard that it is if there is to be intervention, it's much, I don't know if easier is the right term, but it's much easier to see good results and good outcomes if the intervention happens at a younger age. The older and more kind of, the older a person becomes, the more intractable the problem becomes, is my understanding. Do you find that to be the case?
You are absolutely correct. So, and this is, again, another thing that's well documented and has been studied in the research. And that's in large part due to brain development, right? Not only do these ACEs or potential traumas impact the brain development, right? Potentially change brain functioning and structure, as well as our emotional and psychological responses, but so do the interventions that we do, right? So the idea is that if we can counter these things with therapy, with medications, with support, with security, with just comfort and love, that we can counteract some of those problematic changes. That's the goal. So the earlier we can get involved and do that, the better chance we have. I think the good thing is that we have a much better understanding about brain development now, and we know that really until you're in your mid-20s, your brain is still pretty much a mushy mess, and some of the hardwired paths don't develop. So we have plenty of time with JJ to make some interventions.
I noticed, or what stuck out to me is that his mother was on, she was abstaining, but she obviously had an addiction to heroin in the past. So for how long, we don't know. And how that impacted his life, we don't know. But obviously that's a huge factor, I would imagine.
Absolutely. Yeah, it's indicative of those of that ACE, right? It's there. That substance use in a parent is a big one. And it's just so destabilizing. All right, Dan, the next slide. Oh, sorry.
Never mind.
I just think we also need to give JJ's mother some support and help. She's kind of crying out that she knows that this could lead to her going back to heroin use because of the stress. So along with JJ, I think we probably need to help mom, so she doesn't go back to her heroin addiction.
You're absolutely right. Absolutely. Other thoughts?
Yeah, I don't know how you would help him as a teenager, because certainly you won't want to go into counseling unless it's with other teenage boys, where maybe it would work in a group setting where he's not alone in that type of discussion about it, because he's already so entrenched in this behavior. And of course, a lot of drug abuse is inherited, or addiction behavior is inherited. We don't exactly understand why, and he's already started to use drugs, so he could easily get into that big time.
Yeah, you're correct. In terms of the effectiveness of the therapeutic approach, it varies a little depending upon what you're going after. If it's just opposition, if it's just JJ's kind of oppositional response to the world, then involving him in sort of more comprehensive therapies with other boys, with other family members, would be the best route. If you're able to get in there and get to some of that cause of that anger and aggression, then the individual therapy route can be quite useful, but you have to sort of be able to break that surface and get him to start talking. All right, let's see what we do, Dana. All right, so this is how we respond to JJ. So we already hinted at a lot of this already. So we want to offer individual therapy for JJ with a strong focus on trauma. If we can build a rapport with him, if we can make the connection, then we're able to get him talking, and we can begin to get him to discuss the traumas that might have occurred to him. We do want to do family therapy, and we would do that, again, via our clinics, via school-based work, where we pull JJ's mom into the therapeutic work, and we get them discussing things amongst themselves. Not only how to respond to JJ's misbehavior, but also having mom understand the origins of that misbehavior, and having JJ understand what mom is going through. So we have partnership programs in the community with some of our big GED programs. For instance, the YO program partners with one of our community clinics to actually provide therapy services on site at the GED program. So this is another way to improve access to care by going to people who need it rather than asking them always to come to us. We want to offer substance use treatment, which we do, right? So when we enroll JJ into our clinic, we're going to do monitoring and maybe even consider treatment for JJ's marijuana use problems. But because we also offer services for adults with both Medicaid and Medicare, we're going to seek to actively enroll JJ's mother into treatment to get, as what was noted, the much needed treatment for JJ's mother, right? We can help her with her emotional issues, but also offer substance use treatment for her. And if necessary, we can even give her medications in order to treat her problems with addiction to heroin. If she's feeling like she's at risk of relapse, if she's having cravings, we might give her even long-term injectable medications to help decrease those cravings and improve her likelihood of maintaining her abstinence. And for JJ, we would think about using our community programs too, thinking about engaging Safe Streets in order to identify other community interventions and resources. That is why we have Safe Streets, in order to work within the community and know about resources right there locally that might be specific to JJ's needs. So we can engage our Safe Street partners and maybe work on identifying some things right in the community that would be helpful for JJ. All right, Dana. All right, so let's do case 3. They're getting shorter as they're getting older, unfortunately. James is a 27-year-old man. He was recently released from prison. He has no family supports and lacks reliable housing. He's never been able to sustain employment. James has a legal record dating back to age 15. In addition, he has a history of heroin addiction starting at age 19 that led to an increased rate of arrest. James is desperate to avoid reoffending, but needs the basics, including stable housing and a job. He also realizes that he needs to remain abstinent from drugs and address his underlying depression. Any thoughts about James?
Well, Dr. Means, the best news here is James wants to do something. And so he's kind of focused on his rehabilitation. I was thinking back to the last example, and the challenge that I kind of see there is whether JJ is even going to want to, address the issues, whereas he or James is raising his hand. And it seems to me when somebody raises their hand, it's a lot easier to be able to, get them into the right programs. And, we see this, I'm involved with living classrooms, and we see it a lot at living classrooms, with our programs there in terms of, people coming back into society from prison. And the ones that really want to do what James is doing have a high degree of success.
You are absolutely correct. It is quite encouraging that he's gotten that level of insight now, and that comes. It's quite often that the teenagers just don't have that, right? They're too young, they're too dumb, but you get a little older, and you've gone through some heartache, and that insight comes that I have to address some things that are affecting me. I think the hard part is that sometimes the hand that is raised is not raised all the way, or it goes up and then it comes back down, right? And that's the harder thing for us to manage is realizing that need or desire is variable. And sometimes it's just variable depending upon the stressor of the day. But for us to continue to pursue and offer services, even though that desire sometimes fluctuates.
I don't know what.
I'm sorry, go ahead, Mary Catherine.
I don't know what your criteria for Christopher Place is, but I know many of them have come out of jail settings. But of course, that's housing for them and a support group that's going to help them move forward and eventually, when they're ready, to look and find a job. But I don't know what your criteria are for getting into Christopher Place.
I would say you're cheating because you know what my next slide shows.
No, I didn't know, but I know about Christopher Place.
You are very astute. And Danny, you can move forward to the next slide and we can continue talking about James. Bill, you were going to say?
No, I think Mary Catherine had it. It's, our Fallsway Clinic and Therapy. It's probably short-term housing at Weinberg if there's not a bed available at Christopher Place, just like you're talking about. I'm glad people are aware of that.
There we
Yeah.
go. I love it. I love it. And that's how we respond to James. This is what we do for James here at Catholic Charities. We
Taught
think
me
about
well, Bill.
we think about short-term housing support at Weinberg, and then hopefully enrollment into Christopher's Place Employment Academy. We know that James is seeking help. We want to offer that help, and it would be great if we can do so via the programming within community services. The great part is that now we also have integrated mental health services within those programs as well, right? We can offer James therapy to begin to address the depression that he's suffering from. We can offer him psychiatry services if he needs an antidepressant. We can even offer him substance use services. We can realize that, James, you need some help maintaining your abstinence, and we want to help you as much as we can. Whether it means just therapy, whether it means therapy and medication, we're going to do whatever we can in order to help James achieve the goal of just basic stability so he can begin to move forward. So I do think that it's quite evident that we have a lot of resources that many of you know about that we would be able to provide for James, and hopefully a relatively integrative, comprehensive way in order to get him on his feet. All right, next slide, Dana. All right, so Bill tried to ruin my surprise, right? What if we don't respond? What do we do if we don't respond to little Jimmy?
Right.
He becomes JJ, right? It's obvious, right? And when we don't respond to JJ, he becomes James, right? They're all the same person, right? Little Jimmy, he's James Jr. and now he's James. You know, he called himself different things at different times of his life, but it's the same guy. And what I hope to show is that, one, how these ACEs impact him, resulting in these high-risk behaviors that then results in poor outcomes for him ultimately. But also how all of those little blue arrows are the interventions that we put in place in order to fight against those ACEs, to fight against those poor outcomes, and hopefully, again, change that trajectory so that James is a much different person than what was presented in case number 3. All right, I've droned on long enough. I'd love to hear your thoughts and comments and questions about the presentation overall.
Dr. Means, I'd like to thank you. You know, having a son that, you know, experienced some of these ACEs and still has the impact as an adult and still struggling to overcome some of it, you know, it was very helpful to me in terms of your commentary, in terms of how the brain gets rewired and a lot of the actions people take later in life, you know, are a direct result of the ACEs that they experienced as children. So I thank you for that. And Bill, I do have a question in terms of what has been the impact of COVID as it relates to Dr. Means' work? You know, when I think of Weinberg Housing and you know, and Christopher Place, and you know, are we still able to provide the holistic services that Dr. Means is focused on to the same level?
Yeah, Dr. Means can address it as well. Our behavioral health clinics, for sure, have been primarily telehealth, but people with substance use disorders that we're providing medication administration and management for still have face-to-face. And the clinic is located, the Fallswood Clinic, right on the first floor of our Daily Bread and supports the men at Christopher Place. So on that part of the continuum, it has worked perfectly, well, yeah, as best as possible. And I think our school-based services are still remote at this point for the most part. I think, and Dr. Means, why don't you weigh in on it? I think the observation of seeing somebody in their living environment that doesn't live with us through telehealth has given us at times, you know, a different perspective and insight to the dynamics that we might experience in the in-person clinic setting.
Absolutely. It's been an interesting experience now that we're providing all of our services via or most of our services via televideo, right? So families stay in their home, and because of allowances, waivers about the way we can give care, we are allowed now to actually just sign in with them on their phone while they're at home. and provide the service that way. So it does provide this interesting perspective. Yeah, there's problems with it, but it is interesting to be able to be in someone's home in that way and see their environment and be able to engage about things that are going on in their home sometimes as a different aspect of care that we weren't privy to before.
Thank you.
I think it's also interesting to think about the step that comes even before the little Jimmy step, which is the systemic issues that should have supported little Jimmy to start with. So that's safe and supportive housing, that's clean water to drink, that's a functioning school system, that is healthcare, wide healthcare access for either physical ailments, mental ailments, substance abuse, those sorts of things. That if we had a cohesive system that supported folks that needed it, that Jimmy might still have had parents or a family that had struggles, but those struggles would have been addressed in a different way, right? We think of ACEs a lot of times as, how did me as an individual child what were the interactions with trauma that other individuals in my family had, right? So like my parents had the trauma which resulted in domestic violence, and I witnessed that, right? But we don't talk about ACEs in terms of a systemic, we don't talk about it that way. We talk about it as individuals interacting upon other individuals, mostly, other than things like tornadoes and hurricanes, which I know is another part of ACEs. But I just think thinking about the systemic piece that comes even before a child experiences individual things is another interesting part of the conversation.
No, I think that's a crucial part of the conversation. It's one that I think you can think of it from two different vantage points. One, we all know here at Catholic Charities that we do a lot of work, we do a lot of advocacy, we do a lot of legislative work to address those systemic issues, right? And that's where that starts. But I like to think, I hope, I pray, and this is what drives me sometimes to deal with some of the sadness that comes along with clinical care, is that by affecting Jimmy, by affecting JJ, by affecting James, I'm then hopefully resetting that cycle in some way so that, James the third, doesn't have these same ACEs, right? Because I've affected James the second or James Jr. I'm getting too complicated here. But that's the idea, is that, we've changed these things generationally. Maybe we're not fixing those things now, but for the next generation, we are making some impact because we've made some individual changes with the people that we're seeing.
Are there any other questions or comments for Dr. Means? Well, Dr. Means, I just want to thank you for sharing your time and talent and for leading us in this thoughtful discussion and presentation. I also want to take this time to thank all of our guests for taking time out of your schedules to attend this session. Our next session will be hosted on Thursday, October 29th at noon, and we will be discussing the topic of volunteerism with Mikkel Christensen, Director of Community Outreach and Volunteer Services for our Family Services Division, and Julie Martin, who is our Volunteer Manager at My Sister's Place Women's Center. We hope that you will be able to join us. Take care and enjoy the rest of your Thursday. Thank you, everyone.
Thank you. Thank you, Dr. Means.
Thank you,
Take care,
Dr.
everyone.
Means.
Have a great day.
All right, take care.
Bye.